On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
Roxana, thanks very much. Long title indeed, but a short presentation here for the press conference. It's a pleasure on behalf of all the co-investigators in the ISAR-DESIRE 3, which was a 3-center trial in Germany, to share with you for the first time then the results. I don't have any disclosures related to this presentation. By way of background, I think it's important to state that despite over a decade of experience with DES in real-world clinical practice, we still don't know the optimal treatment of restenosis within these devices. Now we know from some smaller studies with drug-eluting balloon therapy that this seems to be a very promising therapy, particularly in patients with bare metal stent restenosis. It has the advantage of avoiding additional stent layers, and if we can achieve good results with drug-eluting therapy, comparable with that with DES without requiring additional stent layers, I think that's a very exciting prospect. So this is the design of ISAR-DESIRE 3. It was a prospective, randomized, active controlled, multi-center clinical trial. The key inclusion criteria were stenosis more than 50% in a Limus drug-eluting stent, accompanied by symptoms or documented signs of ischemia. The key exclusion criteria were left main stent, restenosis, implantation or treatment in the setting of STEMI or cardiogenic shock. The study hypotheses, just to point out for you, this study had dual hypotheses. So the first was non-inferiority. We hypothesized that the Paclitaxel-Eluting balloon, the sequent balloon, would be non-inferior to repeat stenting with the Paclitaxel-Eluting Taxus Liberté stent. And the second hypothesis were that both the Paclitaxel-Eluting balloon and the Paclitaxel-Eluting stent would be superior to balloon angioplasty alone, which we included as a control arm. Now you can see that between 2009 and 2011 at our 3 centers, we recruited 402 patients. They were randomized a 1-to-1-to-1 fashion. 137 were treated with the Paclitaxel-Eluting sequent balloon, 131 with the Paclitaxel-Eluting Taxus Liberté stent, and 134 with balloon angioplasty. We had a rate of angiographic follow-up, 84.1, and clinical follow-up 12 months data was available on 97.5. No significant differences in either of these follow-up parameters across the treatment groups. So these are the primary results. Then the primary endpoint was percent diameter stenosis at follow-up angiography 6 to 8 months after intervention. These are the cumulative frequency distribution curves, which I will show. We can see, first of all, with the Paclitaxel-Eluting balloon, a mean percent diameter stenosis of 38.0. If we look at the Paclitaxel-Eluting stent, then we see the curves are overlapping, and the mean percentage diameter stenosis at follow-up was 37.4. On the basis of this, we could conclude that therapy with PEB in comparison with PES was non-inferior with a high degree of statistical significance. We've got a P non-inferiority value of 0.007. So moving on then to look at the second hypothesis then, how does this compare with balloon angioplasty alone? Balloon angioplasty alone, you can see a significant right shift of the cumulative distribution curve, so we have a mean value there of 54.1, and as a result, the second of our hypotheses showed that both devices, the PEB and the PES, the Taxus stent, were significantly superior to the balloon angioplasty, high degree of statistical significance. How did the secondary endpoints compare? Well, actually, they were in keeping with what we found in the primary endpoint. If you look at binary restenosis, first of all, you can see 26.5 with the PEB, the sequent please, 24.0 with the PES, no statistically significant difference between the groups. And on the other hand, if you look at balloon angioplasty, significantly higher binary restenosis, 56.7, P less than 0.001 for both comparisons against the PEB and the PES. TLR, then clinical restenosis, also broadly in line. PEB marginally higher than PES for this parameter, 22.1 against 13.5. P-value not statistically significant, P 0.9. And again, balloon angioplasty, you're seeing significantly worse outcomes, 43.5% target lesion revascularization with balloon angioplasty alone, P highly statistically significant. So I think then we can conclude that in patients with DES restenosis, in the ISAR-DESIRE 3 dataset, we've shown that PEB therapy is non-inferior to repeat stenting with a Paclitaxel-Eluting taxus stent. And I think, intriguingly, we can suggest that by obviating the need for additional stent implantation, treatment with a drug-eluting balloon should be the treatment of choice as a treatment default strategy for these patients. Thank you for your attention.
Thank you. A very, very nice paper. This is open for any questions from the press. Bert?
Do you have any data on what stents were originally that had restenosed?
Yeah.
Were they paclitaxel, sirolimus?
Yeah, so this study was limited to Limus-eluting DES, so we can't extrapolate these findings to Paclitaxel-eluting stents. So we had sirolimus-eluting stents, so taurulimus-eluting stents, biolimus A9-eluting stents, so the spectrum of Limus-eluting stents. I think Paclitaxel-eluting stent in de novo lesions makes up a small component of clinical practice nowadays with high efficacy second generation Limus-eluting stents. But it's important to comment that these results are restricted to patients with a Limus-eluting DES.
Great. And one follow-up question, are you going to be following these patients further? Or?
Yes. Yeah, we have a protocol-defined follow-up at 2 years also planned, and we will also follow these, as with our ISAR cohort patients, out to 5 years.
Crystal Phend with MedPage today. I'm just going to back a step up. Why would it not translate to Paclitaxel-Eluting stent restenosis? What's the difference that you would expect?
Well, we think there are some differences between restenosis occurring within Paclitaxel versus Limus-eluting stents. You know, this is something where drug hyporesponsiveness may play a role, and we chose to exclude these patients from the current analysis on the basis, as I say, that they make up a small proportion of our patients in routine practice. But I don't think there's strong reason to believe that the results with Paclitaxel-Eluting balloon and Paclitaxel-Eluting stent would differ that dramatically, but obviously I can't speculate on that from our data set. Yeah, I think we know that drug-eluting stent restenosis is certainly a multifactorial problem, and drug hyporesponsiveness, resistance to the initial agent certainly plays some role in this process. Whether it plays a lead role or a relatively minor role, we don't know at this time point.
Next question.
This is Reed Miller from theheart.org. Can you comment on the safety of this balloon procedure versus putting in another stent, or is that something you're going to have to wait and see longer term?
No, with the restrictions of time and slides here, I haven't shown the safety data, but there were no differences across the three groups. If you look at the composite death myocardial infarction, very similar rates across all three groups, so no adverse safety signal then. And if you look at target lesion thrombosis, we don't refer to stent thrombosis in these studies, normally target lesion thrombosis, and here we saw low rates across all three treatment groups with no difference.
So I have a question.
Mm-hmm.
What about the patterns of in-stent restenosis? Were those equally distributed? Limus drugs are mostly focal pattern, but did you make sure that there was no issue regarding the more diffuse pattern, let's say in the balloon angioplasty arm versus the others?
Yeah, I mean, yeah, very good point. I mean, this study, I think, nicely shows, you'll see in the main presentation, that the patterns of restenosis at baseline were well distributed across the groups, as you would expect in a randomized trial with allocation concealment. But we're seeing very reproducible results. We're seeing 2/3 of patients have focal pattern restenosis, 1/3 have a non-focal pattern, which includes diffuse, and obviously in a small minority, proliferative beyond stent and occlusive restenosis.
So was the restenosis related to the pattern at the time of presentation, or regardless of the therapy? Did you see that more diffuse patterns of in-stent restenosis were more recurrent even after treatment with either one of these devices? Did you look at that?
We have preliminary. I've preliminarily looked at that, but actually I don't have the. I won't answer that definitively at the moment. I don't have that final data to hand.
Dr. Silva.
So question. Well, congratulations. Important study. Now we have to update the European guidelines because the drug-eluting balloon is used in Europe. It's CATF certified, and we have recommended in the guidelines only for bare metal stent in-stent restenosis. So thanks for giving us the job to update it. My question is, we know for many years that just plain balloon angioplasty is the worst treatment for in-stent restenosis. And my question is, why did you include the group? There was another study from Japanese group, Havara, published that did exactly the same. They looked at in-stent restenosis in Limus in-stent restenosis patients, compared the drug-eluting balloon to POBA balloon, and the drug-eluting balloon was highly superior to poor old balloon angioplasty. And is it ethical today to use just the plain old balloon in in-stent restenosis?
I think it is. Certainly at the time that we designed the study, I think this is one of the, we didn't have that data available. Now a number of studies have come out, including recently the PEPCAD-DES study, which was published in JACC to show differential late luminal loss between balloon angioplasty and Paclitaxel-Eluting balloon. I think the nice thing about including balloon angioplasty, it enables you to quantify the effect of PEB, because otherwise you're comparing it against PES, and without getting too technical, obviously you've got different degrees of acute gain, and therapies with higher acute gain incur more late loss. So I think it's very important to have a balloon angioplasty control in this study.
So, Jim.
Yes, congratulations. This is, again, a very important study. I think although less common, in-stent restenosis within DES continues to be a problem, and often these patients have multiple layers of stents as they're treated over the years for this. So I think this is very important. One of my questions was, and this is sort of in the context of the morphology, any sense of how many of these were actually fractures that came back as restenosis, or were those excluded?
You know, I think this is an important point, and this is something that comes up in terms of what baseline imaging do you do when you enroll these patients? Do you have systematic IVUS? I mean, sometimes we see fracture angiographically, sometimes we require intracoronary imaging to see it. In our ISAR-DESIRE trial series, we've basically enrolled all comers with DES at the centres involved, so we don't systematically exclude patients with stent fracture. Now, it may be if a patient comes with a very obvious disconnect in the stent, that this patient is not represented in the study because they have a scaffolding problem. But we don't systematically assess with intravascular imaging to look for stent fracture.
So one quick point of clarification, then a quick question. There has been studies done using opposite antiproliferatives, and they haven't shown, that is with stents, just to answer the question that came from the press, and they haven't shown a material differential in effectiveness. So I think that's one thing.
Yeah.
And the second question I wanted to ask you, looking at the TLR, I assume some of this was driven by the angiography, and to the extent that's the case, do you think that the TLR in a stented vessel, secondly stented vessel, is different than the TLR in a singularly stented vessel, and that the eye just tends to want to open the single stented vessel? If you understand my question.
I understand that fully, and I think that's a relevant factor. That certainly that would play a role in the decision to re-intervene the number of layers of metal that were already in the stented artery.
Great,
yeah. I mean, just getting back, that's Dr. Gray raises a good point. I think perhaps I didn't answer your question directly, but we certainly have randomized trials. You can look at our ISAR-DESIRE 2 study, which we presented here at TCT a couple of years back, looking at staying with the same drug against switching to another drug. And there, in a randomized controlled trial setting, we didn't see any difference in outcomes between the two strategies.
Are there any questions from the call? Anyone on the call have a question? I'm sorry, I forgot to ask that before. Okay, wonderful. Thank you very, very much.